Go live? All right. We're just waiting here for a few seconds. Hi there, Facebook world. We're live here with Dr. Nicholson. This is Tyler Thayer. I'm the co-founder of Project Heart and the CEO. We're just going to wait while a couple people hop on live and make sure that the audio is all synced up and everything looks really good. But we're really excited to have you today, and we're going to just wait here for a few seconds and kind of make sure, wait till Sydney comes back in the room, that everything looks good. I don't know what else to say. Seeing if it is, what do you think? Is it looking good on the, can you find us on that, on the computer? All right, well, it sounds like we're good. So sounds like we're up and running. All right, well, anyways, welcome everyone to our monthly video cast. Our goal, well, like I said earlier, my name is Tyler Thayer. I'm the co-founder of Project Heart and the CEO. We are here every month to host a doctor, a scientist, a researcher, an investigator, anyone who is on the path as we are to cure CHD and in particular to grow hearts as well. And so we're really excited about where this program is going to take us. We will be, over the next couple months, we will be interviewing people that we have already interfaced with, either by a grant or we've been having a good relationship with them and kind of highlighting who they are and what they're doing. And then as we continue to grow the podcast, we'll bring in more people around the nation to share more information with you guys out there and hopefully just spread awareness and really get to understand more about what's going on in CHD research and cardiology research. So before we keep going, I wanted to introduce our guest today. This is Dr. Nicholson from Monroe Carroll Jr. At Vanderbilt. And so, hey, welcome.
Hey,
how are you?
Call me George, please.
Okay, George.
Yeah.
All right, well, this is George. George, tell us a little bit about you. Kind of update the people out there who don't know you and
Sure.
what your role is at Vanderbilt and what you do.
Great. Well, from New York originally, and I did my my med school at Loyola in Chicago. It was a great school, great place to live as well.
Cool. Yeah.
Went back to New York for my residency in pediatrics at Montefiore Children's Hospital, which is Albert Einstein's teaching hospital, and did my fellowship at Emory University, both my cardiology fellowship and then my additional year in training for interventional cath.
Okay.
And so and then I've been at Vanderbilt now for 4 years, and I am specifically one of the interventional cardiologists. Both myself, Tom Doyle, and Dana Jansen, we formed the interventional cardiology team at the Children's Hospital.
Yeah, you guys rock.
We just try to do our best every day. Yeah.
Well, and everyone over there is like some of the most beloved here in Nashville and really regionally. So, and you guys are definitely integral to that. So, thank you for all you guys do over there. Yeah. So, tell us a little bit more about your role. Like, what is that team? What do you guys do? So, anyone that might not know exactly what you guys do, can you kind of talk a little bit about your day to day and the tools that you're using and how that relates? Because you're not doing open heart procedures, you're doing something completely different.
Yeah, exactly. We'll do, there are a number of different things that we can do in the cath lab. Usually what happens is we actually use the vessels in your groin, usually your artery and your vein. We also go through your neck. We also go through the liver as well. And we follow the path of blood right back up to the heart. And we have kind of specialized equipment that allows us to get into all the different heart chambers and also out into the lungs. And with things such as balloons and stents help, if vessels are too small or too tight, we help make them bigger. Or if you have holes that shouldn't be there, we have other devices that we can implant into the heart. Again, all not necessarily having to go through the chest, but to help out the heart defect. And there are other times that we'll work with our surgeons, and we do something called a hybrid approach, where the surgeon will help us get access. Let's say if the child is just too small for us to be able to use those veins, or if the procedure that we're doing just takes equipment that's just too big. Mm-hmm. The surgeon will help us where they'll potentially open up the chest, but you don't go on what's called bypass, meaning you don't have to stop the heart.
Right.
But then we're able to go directly in through the chest, which is opened, and do what we need to do to try to help the child or the adult out.
Cool. I think, so a couple years ago, if you guys are out there, scroll back on our Facebook page, on our videos to a couple years ago, after this is done. Not yet, don't go away. But we did a little, it was really cool. So as a parent, so my son having CHD, I've never actually been in a cath lab, so and most kids are probably either loopy or just about asleep by the time they get in there, right? So we don't really see what the cath lab actually looks like. Gotcha. But a couple years ago, we got to shoot a video with Dr. Doyle when we first sponsored his stent and well, project you're working on as well. And we did a video interview of him and took some photo shoots. And the cath lab is like really cool. I was kind of like, I'm nerding out a little bit because it's like this humongous CT. It's a CT, right? Or is it?
No, fluoroscopy.
A fluoroscopy. Okay, so that's a little bit different. Tell us a little bit about the equipment in that room.
Sure.
And then you guys, after this, go and check out the video because it's really cool. But
so we use fluoroscopy, which is kind of like real-time X-ray.
Okay.
And it's what we call biplane, meaning you have two separate cameras. So you get two angles to look at, and you can move them however you want them to go. So it's not just straight here and straight through the side. We can go in at all different angles.
Cool.
And also what we started to do too is kind of a 3D angio, which means we'll inject the dye, and the camera during the injection will rotate all the way around the individual on the table. Yeah. And then we're able to reconstruct these pictures real time to get a better sense of what the CHD lesion is and what our plan is going to be. You know, it's a whole team approach there in the lab with cardiac anesthesia, not only the interventional physician, but also the scrub tech, the nurses, everyone.
Yeah. How many people is in that room?
Just like
a
regular case,
procedure, yeah.
let's say. So you usually have an anesthesiologist, and then you also have a nurse anesthetist. So that's two folks right there at the head of the bed. And their obviously job is to make sure everyone stays, well, not everyone, but the child or the patient stays asleep.
Right. Yeah, we don't want that one.
Yeah, no.
We don't want loose
and then,
valves or anything.
Yeah,
no. Would not be good, so.
And then there's the interventional physician as well, along with the scrub tech. Oftentimes we do have a cardiology fellow because we are a teaching hospital, we're a teaching institution. And then really throughout the country too, the pediatric interventional world is relatively pretty unique in that, you know, not every community hospital has a program. Right. So usually it's the big academic teaching hospitals throughout the country. So usually there's a fellow. It's a great place to learn too, as part of their training. And then there's a circulator who's running around getting all the stuff that we're asking for, and then there's a recorder. So it's a fair number of people in the room at any one time.
Yeah, that's cool. So talk a little bit about what is Vanderbilt in particular, your team, what's the range, do you know how, like the range of people that you serve? Because you're a bigger institution. You're seeing people from really almost all the states that touch Tennessee, I would expect. But,
yes.
Where is that range in these bigger institutions?
So it really depends also on where you live.
Sure.
So if you're up in, let's say, New York, where it's a really densely populated area, you know, there are probably 4 or 5 programs just within the 5 boroughs, right there. Yeah. In a state like Tennessee, there's us, and then Lebanon and Memphis, and that's really it for the state in terms of pediatric intervention. Most states have probably about 1 program. I mean, certain states such as New York, Texas, and California have more than 1 just due to their population. Right. But then there are a number of states that don't have any, such as the Dakotas or out in Idaho. And so it can be pretty drastic in terms of the differences. Yeah. And for us, we take care of anyone who's a premature infant. You know, the smallest child that I've done a procedure on and put a device in weighed a little over 2 pounds. Wow. Versus up to adults, you know, 50s, 60s. Right. So it's a pretty wide range.
Wow, that's crazy. Yeah. Well, let's talk a little bit more about you. How did you get into the field of cardiology? What was it that said? Did you know from going into school and even doing your bachelor's, or just like getting into college, that you wanted to do this, or is this something that kind of evolved later?
I always had a sense that I wanted to be a doc. Okay. I just, even going back to high school, loved it. But with that also being said, I was an economics major in college. Interesting. And just because I found that also to be quite interesting. Also, to tell you the truth, pretty helpful in the current landscape of medicine too. I didn't get much exposure in med school to pediatric cardiology, and I don't think that's too uncommon. I don't think a lot of med students get a real in-depth exposure to this field.
Yeah.
It wasn't really until my residency that I did a cardiology rotation in my second month of intern year that I just said, this is it. I really enjoyed my surgical training in med school and my rotations there. It was a tough choice between surgery or pediatrics.
Right.
But then once I found cardiology, I just loved it. I mean, the heart's a pump.
Yeah.
They try to you're trying to problem solve with the pump. I just found it fit the way that my brain works.
Yeah. It's interesting. So just being introduced with Calvin, kind of wondering like, man, why did God give me, like, why is this happening to Calvin, right? But I'm an architect by trade.
Yeah.
So like by day I'm an architect, and by night, nonprofit, go-getter, whatever. Well, the interesting thing is we're actually now doing more of the nonprofit during the day, not how it started, but and the team that's right here behind the camera. So
well, you're doing a great job with it.
Yeah, they are. They're killing it. So, but the interesting thing is, as an architect, I remember talking to our surgeon, and he was just talking about the pump nature of it, and I was like, man, this is all pumps, fluid dynamics, and valves, and things that I understand as an architect that deals with plumbing and all these kind of things. And so, I instantaneously knew like, hey, I got to get involved, and I think I have the kind of the pumping nature and the fluid dynamics. I understand this enough to be able to be dangerous enough to say, hey, we can do something about this. I don't know it on your level, but
oh no, you've gotten a crash course over these last few years.
Yeah. I think Eric and I, we were like, we deserve our honorary nursing degree.
That's right.
And the nurses are awesome. They teach us all along the way. So,
if you have good nursing staff,
oh yeah,
that changes absolutely everything.
Yes, 100%.
Yeah.
Well, so what about is like the most rewarding thing about your job? So you figured out, okay, here's what we want to do. You love the pump, but like, where do you get like, what's the joy part of this? Like, why do you come back to work every day?
The joy is just seeing the kids, and knowing that you can hopefully really help, and you have a child who's otherwise pretty sick and just not able to do all the things that every child wants to do.
Yeah.
And achieve the goals that they want to achieve as they kind of get older and move into adulthood, and just helping people just live the life they want to live.
Right.
And that's what keeps me coming back every day.
I imagine it's kind of the hardest thing too. It's kind of like a double-edged sword.
Yes, in that there are certain things, as in every aspect of life, there are times where you can't help.
Right.
And that's when the days are bad.
Yeah.
Yeah, but fortunately, the good days far outnumber the bad days.
Right. You guys got a good crew out there, so I'm sure the camaraderie is pretty tight.
It is. I think we have a great team.
Yeah.
I feel very fortunate to work with the folks that I work with, and it's just we're collaborative. Love having relationships with families.
Yeah.
And other teams and other organizations, just because everyone's goal is the same.
Right.
Right. It's to fix, if not cure, whatever problem that anyone's faced with.
One day we will.
Yep.
I fully believe it. So, well, let's get to the meat of the discussion, which is CHD research. And so, I mean, that's what we, when Eric and I started this 4 years ago, we said, well, hey, there's a lot of groups doing awesome things to care for parents, to care for the kids, to care for the adults, doing a lot of great programs. There's not a lot doing CHD research. And so when we started this, we were like, okay, we're going to focus in on this and ultimately we think, hey, this is the best way we can long-term care for these people is like how do we find a cure? So let's talk a little bit about that. Where do you think, I guess you've been in, how long have you been in cardiology about?
I've been at Vanderbilt for a little over 4 years since my training ended.
Okay, and that's when you started cardiology?
That's when cardiology, if you add up my fellowship time and this, it's a little over 8 years.
8 years, so in the past 8 years?
Yeah.
Well, in 8 years, a lot of this has changed, honestly. But so in the past 8 years, because I mean, like even 4 years ago, Calvin's 4 now. Even 4 years ago, we're doing things differently. Like I feel like some things have changed. But in the past 8 years, what is like one of the biggest things lacking in CHD research? What's lacking? Where do we need to go?
Got it. I think from a broad sense, there are two big areas. One is funding. If you look at the amount of funding that goes towards, and I'm talking like national funding, NIH level, if you look at the amount of funding that goes towards pediatric cardiology or just congenital heart disease, whether it's pediatric or now adult congenital heart disease, it's really a minuscule amount that actually goes towards that research.
Right. Yep.
And then the other thing is time. A lot of us who have a vested interest in advancing the field and improving care, we also have obviously clinical duties as well, and we're being asked to do more and more from that standpoint. And so I think those two big areas are where I think it's been a real struggle for the field. Yeah,
and I guess I see that because I think you guys are, and it's been this way forever. What was that movie that came out a couple years ago? It was about the BT shunt.
I know. Yeah, something the Lord made.
The Lord made. Yeah, something the Lord made. That was a good movie. If you haven't seen it, go see it. But it's like on Netflix, I think, isn't it? I don't know. It's on Prime, Amazon Prime. Okay. Well, anyways,
just don't go to Blockbuster.
Yeah. Good luck if you can. But I think one of the things that interests me there was it's actually the actual clinical and surgical groups that were pushing this, and then it's kind of like so it was experimental. We're taking this. We're now children are living when they used to not live, and but now we have created a problem, right? So it's a good problem to have. Children are living.
Yes.
And they're living into adulthood, and for the first time ever, we have more adults than we have children with CHD, which is kind of crazy. And it's only a recent development, really. But now we have to take care of all these people, right?
Yes.
So where it was the surgeons, the cardiologists doing that kind of research and experimentation to kind of get us to where we are now, we're now bogged down. So now we need really new minds to come into this field and really take on the research, the investigations, the activities that are like partnering with you guys that are in the clinics as well, and like having that good partnership. But you need full-time people working on this because, and I've learned this from Project Heart, just saying, if we're going to turn Project Heart into a national organization that's doing this and actually making a difference, Eric and I can't do it in the evenings.
Nights or weekends.
Yeah, nights and weekends. Like you just can't do it.
No.
But you really need to you need to have full-time people, and hence like the staff that we got here that's like really pushing it. And honestly, Project Heart's just I almost can't believe where we are, right? So, but I totally agree. So then this is part of the things that we want to do is we want to get and put people into that position that's full-time, partnering with the clinical staff, but kind of takes the load off a little bit to get more work done.
Well, I think you hit the nail on the head here in terms of it takes more full-time people, but also if you look at research traditionally, I think the future is moving away from small single center or single individual results or reported outcomes. It's collaboration. Right. And so we just said about we want new minds coming into this. I think new minds come in the form of new collaborative teams. For instance, whether it's in the field of pediatric cardiology, working with biomedical engineering, and all coming together as the same team, or in terms of at the bench in terms of valve development, or just kind of tissue engineering. Right. Is that because we all have our areas of knowledge and our areas of expertise, but I think you need multiple people from multiple areas to form a big cohesive team if you really want to advance the field.
That makes sense.
Push the team.
Yeah, that's kind of where we formalized Project Heart as a nonprofit. We're essentially owned by the public, right? The public gives the funds. We are just the stewards of this money, right? And so, our mission is awareness and CHD research. But it's our desire. The reason we positioned it that way is so that it would be a public collaborative, essentially, so that those funds, by its very nature, by being publicly owned, by being these funds are coming from the public out of their own generosity to kind of see this happen. The work that we do in the institutions must be collaborative. It has to be shared. It has to be. It has to break down the bureaucratic walls, right? So that are so difficult. But
and some of those walls are pretty tall.
very, very tall and very thick. And yes, but that's the nature. I think that's the power of a nonprofit. That is very interesting because I've never did anything nonprofit before this, but. There is a sense of like when the community gets behind a project spearheaded by a nonprofit, it can start to scale or break down or climb over those walls and really make some things happen and hope and by being a little bit entrepreneurial about it, we can get there faster, I think. But collaboration, 100%, from different disciplines, from everyone, and bringing them all together with a common goal.
Exactly, because also that just helps the enthusiasm for everything going forward. Like I think, as you said, I think one of the biggest things behind these nonprofits, and when people really get behind that goal or that whatever they're passionate about, is that enthusiasm that it brings is able to really break down a lot of those walls. Yeah.
So speaking of collaboration, you introduced me about a year ago, I do believe. This was our last birthday, so it was exactly a year ago, to CCRC.
Yes.
Tell me about CCRC and your role and what you guys are doing, who you are.
So the CCRC stands for the Congenital Catheterization Research Collaborative. And collaborative, and it's a group that initially started back in kind of had its infancy was in 2013, but really in 2015 is when it expanded, and it's 9 centers now from around the country, and it's about creating robust multi-center outcomes-based research. Right. As I mentioned earlier, kind of the days of saying, hey, this is our single center and we have like 15 cases and this is how we do it, and putting it and publishing it in a journal and then having everyone basing all their decisions based on 15 cases. I think those days are behind us. Yeah. And really only when you get multi-center collaboration, because you need a lot of numbers in terms of if you want to really thoughtfully examine outcomes. Big data. Exactly, big data. Right. Got to have big data. But you also got to make sure that the quality of that data going into it is good and reliable. And so it's been a productive collaborative. And what we're currently looking at is actually outcomes in tetralogy flow in infants who require either surgical repair or an initial palliation within the first 30 days of life. And it's from 9 centers around the country, and it should, once we get it out there, it will be the largest reported cohort in terms of looking at those data.
Now, is this the same project? You and a couple of your colleagues, I think in the CCRC, submitted just recently a grant application to us. Is that right?
Yes. So it's part of this project.
It's part of it. It's like
we're looking at actually neurodevelopmental outcomes in these infants, and is there a difference in neurodevelopmental outcomes based on what your initial treatment strategy was? So you've come to the initial fork in the road, and then depending on which side you go, is there an outcome based on that? And both myself and Dr. Jeff Zampi from University of Michigan are leading that project.
Great, very good. Well, we've turned it into the powers that be to have it reviewed, so we'll let you know.
Well, I appreciate even taking the time to review it.
Absolutely, well, we're excited. So.
Yeah, and I think not only from the collaborative is expanding from just interventionalists to non-invasive cardiologists to cardiac surgeons, so you kind of get a whole breadth of experience and ideas to come in. Yeah,
so from a collaborative multi-center, you said there's 9 centers that are involved in this. Can you tell me who those guys are?
Of course.
Yeah, who are they?
Well, it's us at Vanderbilt. It's Children's Healthcare of Atlanta, Children's Hospital of Philadelphia, University of Michigan, UCSF, or University of California in San Francisco, Washington University in St. Louis, Baylor, or Texas Children's Hospital, University of Alabama, and I think that's 8. Oh, and Cincinnati Children's. Sorry, Cincy.
They'll forgive you. It's okay. I put you on the spot. You're on live TV, basically. Well, we'll make sure to, Kara, can we put a link after this to CCRC, just so that people can check it out, and anyone out there can check out all the work you guys are doing. So we'll make sure we put a link to CCRC.
I think Thank you. I also think it's also good for Project Heart as well, because at those others, it increases your net of contacts too, to folks in those various cities and other organizations similar to Project Heart.
Yeah. Well, and it has, and I think, and we've slowly started to grow outside of just the Nashville area. We're located in Nashville, but we really want to see some of this collaboration happen from some of the best minds across the U.S. And you just can't do that located in one way. And the cool thing is conference calls and video teleconferencing has made that super easy, just to hop on a video chat and like talk to people from anywhere, and it's like unprecedented the amount of work that we can get done so quickly across multiple states. So.
Fantastic.
So what kind? So tell us a little bit more about the projects. This TOF project. So is that what the CCRC, that's like the main one that you guys are doing, or do you have some other projects going on?
Well, we kind of roll from project to project. Right. So the initial one from a couple of years ago was looking at outcomes in a certain lesion called pulmonary atresia tachyventricular septum, in terms of looking at outcomes once you potentially open up the pulmonary valve that just never developed. Right. The project following that was looking at outcomes comparing stenting of a ductus arteriosus versus a BT shunt, because the stenting of a PDA is becoming much more commonplace, and so that was looking at it kind of going head to head, but looking back, and then this tetralogy of flow study is the most recent one, and so. To date, what we've done is have a main project, and then you can get a number of ancillary projects off of that main one, because you want to frankly investigate multiple different aspects of a disease, of a type of CHD lesion.
Well, it's one of the things I love, and talking about the PDA stent as well. Because you guys are working on one of those, and we've been working with you guys on that, you and your team here at Vanderbilt. And so one thing I love about your specialty is that, when we start to develop these PDA stents and things like that, for children like my son, he may not have qualified, but, for a lot of children who have some severe heart defect, would be spared potentially spared that first surgery at 7 days old. So Calvin had his at 7 days old, just like a little kid, right? Like nothing, just 7 pounds or whatever, 8 pounds, and like, just barely getting started on life, and has this. Well, if we could do this in a much, I feel less risky procedure in the catheterization lab, and spare that kid until he's older, like that is pretty cool.
I think even if you can buy a couple months, it's a dramatic difference.
Absolutely.
As you know, in terms of congenital heart surgery, our surgeons do amazing things. Yeah. If you think about the size of a child's heart and an infant's heart, take a look at their palm, and that's about the size. So in a newborn, it's like the size of a strawberry. Right. And when you have to undergo such a stressful surgery, obviously not only emotionally stressful for the family, but just physiologically very stressful, is that you have to account for the care of every other organ in the body. Yep. And that recovery is, as you know, and as other parents know of children who have CHD, is that we can get the plumbing and the blood going to where we need it to go, but the downstream effects on other organs and their time to recover is not too commonly the limiting factor in terms of a child's recovery.
Well, let's see if there's any no questions or comments. Anyone got any questions? No problem. Okay. Well, that's pretty much our time today. So, do you have anything you want to add or shout outs to anyone?
Just if anyone is thinking about coming into the field, folks in high school, college, or post college, or in med school, it's a wonderful field to be in. It's a changing, evolving field as everything's going forward, and it really offers for a lot of multi-specialty, multidisciplinary collaboration. And it's an exciting time to help try to push the field of CHD forward.
Well, thank you for your time. Thanks for coming out. And thank you guys for tuning in. If you guys have any questions, feel free to pop them down in the comments later, as we'll post this video later, and then we'll be glad if it's a question for George. We'll seek it out and give you an answer back. So If not, thank you guys for your time and have a great day.